So I want to introduce our first speaker. So Anne Aerts, medical doctor. She heads the Novartis Foundation. That's an organization committed to transforming the health of low-income populations by leveraging the power of data, digital technology, and AI to reimagine health and care around the world. She's an MD. She also has a master's in public health, both from the University of Leuven in Belgium, and a degree in tropical medicine from the Institute of Tropical Medicine in Antwerp, Belgium. Anne, would you mind coming on to the mic here, please?
Thank you so much, Yoon, for the nice introduction. And it's a real pleasure to be here with you this morning. For me, it's afternoon, but I think you are all in the morning zone. So in fact, yes, the global health challenges, as we heard today, are really unprecedented. It's whether we look at the unfinished agenda of HIV, tuberculosis, malaria, like we heard last week at the UN General Assembly, or we look at the rising burden of chronic diseases like heart disease and cancers around the world. And that combined with the inversion of our age pyramid and the need to work across the lifespan to increase healthy longevity have really shown us that we need to innovate the way we deliver health and care. We cannot just continue having these reactive health systems that are in fact care systems that wait for people to get sick before they get treated, to become more proactive, to become predictive and ultimately preventive, so that they can become true health systems that keep their populations healthy. As Bill was saying in the introduction as well, we have to work much more on the health side than on the care side. And obviously that cannot be done by one player alone. We have to work together, whether that's between health players, but mainly also between non-traditional health players in multi-sector partnerships. And at the Novartis Foundation, we have several examples of how that can be very successful. And I want to start by an older example is where we launched a few years ago a multi-sector partnership as an urban health initiative addressing cardiovascular population health. And we call it CARDIO for cities. And CARDIO is an acronym that stands for the O. Let me start with the O is local ownership, because it has to be driven by the local authorities. If you want any of these innovative initiatives to become sustainable, it has to be with the city authorities, the mayor and his or her teams in the driver's seat. The D in CARDIO stands for data and digital technology, because everything has to be data-driven if we want to innovate the way we address our needs in the health and care systems. The I stands for intersectoral collaboration. And let me give you an example there. We worked for accelerating early detection, for example. We worked with different sectors like the education sector, the workplace sector, but also the food and agriculture sector or the sports sector, like screening in football stadia in Sao Paulo, Brazil, yielded an enormous number of people that were unaware that they were living with a cardiovascular risk factor and needed to be treated. The fact that many of the cities where we implemented this were having difficulties for people to have healthy options available, like the capital of Mongolia, where it's 9 months a year winter, you never have access to healthy food. The healthy food options had to become the default choice for people. And that was absolutely difficult, but we worked with the agriculture sector and the supply chain for the food sector to really improve that. And these kind of multi-sector partnerships, they were difficult to set up and not easy to nurture and to manage, but they had very rapid, impressive results. For example, in Sao Paulo, in 1 year of implementation, we managed to triple the blood pressure control rates, and that was the same across African capital cities and Asian capital cities. That translates in up to 13% reduction of strokes. You can imagine how many lives that saved in a city like Sao Paulo with 16 million people. But then COVID hit, and COVID was really putting a spotlight on this intersection between health and society. And COVID also gave a face to inequity that we can no longer ignore. we need to understand better what drives our health and what drives these health inequities. So we wanted to challenge the current realities that where you live determines your health. And we launched our initiative AI for Healthy Cities last week in New York City. This time we work with data-rich cities like New York in the US, Lisbon and Lausanne here in Europe, and Singapore hopefully soon as well, to really bring together data from the health system and data from health influencing sectors, as that is crucial also to address healthy longevity, that we look at what are the social or economic or environmental factors that are really influencing health more so than the health system alone. And this is a partnership where we bring the partners together, again, driven by the mayor. So we had the deputy mayor in New York City opening this with us last week. We work with the mayors in Lisbon and Lausanne, and we really want to use the massive computational power and the data science capabilities of our partners of Microsoft to progress our understanding from what it is that really drives this. How can we address this? So what kind of partners would be most useful to address these unequal health outcomes or these existing health inequities? But then we really don't want to do this as a research program. This is a partnership, again, involving the authorities, academics, private sector players like Microsoft and ourselves, but also community organizations, because we want to make these results translated into action. Otherwise, they will never have a population health impact, which is our overall goal. And to do so, we need to tap into the potential of the health tech innovation. And that's why I'm so excited to be here today with you, because I believe that once we deliver these data-driven insights to policy and decision makers, they will have to decide what kind of gaps in their systems can really be addressed with health tech innovations or overall more multi-sector innovations. And one last example I want to give you there is about our Health Tech Hub Africa, which is located in the center of Africa in Kigali, Rwanda, in partnership with Norsken Foundation. Norsken is the largest impact investor in the Scandinavian countries, where we host 30, 40 startups, local startups, building African solutions to African problems. And we keep them 1 year, we give them a house in the Health Tech Hub. We mentor their entrepreneurial, business, and institutional skills. And most importantly, we help them really fast track their solutions within the public health systems. Because in African settings, as in many places in the world, the health systems is still very much driven publicly. And if you cannot bring your innovations in the public health system, you cannot reach scale or achieve the people you want to address with your health tech solution. So we built, together with the Ministry of Health and the Ministry of Innovation in Rwanda, a blueprint for rapid, fast-tracking innovations, health tech innovations in the public health system. And this will be a blueprint for the rest of Africa, helping health tech innovators really get their solutions to the people who need it. And this happens in so many countries. We've seen in a landscape of the whole world during the COVID pandemic that countries really wanted to scale up their capacities in virtual health services. And countries like Germany introduced very innovative ways of regulations, giving health tech innovators the chance to bring their solutions in the health system for 1 year at the price they wanted. But after 1 year, they have to prove that with health outcome data that they are improving the health of the populations. And only then will they be reimbursed by the health system. Similar initiatives happened in India, where the government wanted to bring massive health tech innovations in the system to deliver virtual services. And we see that eSanjeevi, for example, the massive telehealth service in India, has been downloaded millions of times in a few weeks. So it can happen that health tech innovations come rapidly to scale when there's an urgent need. So I believe if countries now really see the need to work together between sectors to make healthy longevity a reality, that's the way we have to move forward. and make our health systems true health systems. Thank you.
Thank you, Anne, for those wonderful remarks. I have one question for you before we move on to Dr. Mahmood Khan. Where, in terms of the low-hanging fruit, I mean, you've been thinking about this globally. Where do you think the greatest inequities are as you look across the globe in terms of healthy longevity?
The greatest inequities, I think, in the richer countries, because the aging of the population in low and middle income settings is happening, and it's happening fast. However, the social cohesion seems, in most of the countries, seems better still. And there, it is addressed in a different way, where you see the social cohesion, where the social cohesion is lacking, like in our countries here or in the US, I see that the inequities are really unprecedented. And COVID only put a face on that, put a spotlight on it, how big they are. So I believe in the US, in Europe, and in higher income Asian cities, we may have more work than in low and middle income settings for the moment. But that doesn't mean it will not change rapidly, I think.
Thank you for that. Yeah, among the factors that have been observed in these healthy longevity communities around the world that have been identified, observed, and celebrated, social cohesion has definitely been a factor. So to the extent that that can help promote better equity around the world as we move forward, great insights. Thank you for that.